want to point out before we turn things over to our presenter tonight, Dr. Zumer, that May is Spondyloarthritis Awareness Month. And so as an organization, we try to raise awareness, obviously, for this disease and provide resources and information and support for people living with this disease throughout the year. But we pay particular attention in the month of May when things like World AS Day are happening, which was last weekend. And it's really a global effort that we're part of in terms of helping to raise awareness for the disease and the issues around spondyloarthritis. So we also, as part of that, we are asking people to share their stories. So we're looking for people who are willing to share their story of living with spondyloarthritis. So if you would be willing and interested in doing that, please reach out to us at any time. And you can do so through social media, through email, through our website. There's a phone number listed on our website as well, a toll-free number. Any way you'd like to reach out, we'd love to hear from you. And if you'd like to share your story, it will help us to spread that message of awareness and really put a face to the cause, if you will. So please consider that and reach out anytime if you're interested in helping. In the next hour, we're going to be covering some very timely and interesting information about biologics, and we'll be looking at some issues like when and how to talk to your rheumatologist about biologics, what factors to include in the decision-making process, some of the evidence that exists, the uncertainties, what people might expect in terms of coverage and so forth. So there's a lot of information that will be covered tonight, and we do welcome people to submit questions, but we do ask that if you're going to do that, please use the Q&A feature. If you look at the bottom of your Zoom window, you should see a Q&A button there. If you click on that, it'll give you an opportunity to ask a question if you would like to do that. And we'd love to have questions come in throughout the session. And I know Dr. Zumer will do his best to address those questions as they come in. In the meantime, I'm trying to advance. There we go. There's my next slide. So a few housekeeping items. As I mentioned, this webinar is being recorded, will be available. The participants, other than myself and Dr. Zumer and our colleague Dan, are muted so that we can minimize background noise and distractions. But as I said, if you do have questions, please feel free to use the Q&A feature. Just a quick little advertisement, if you will, for our organization, Canadian Spondylitis Association. What you see here is our mission. We exist to provide support, education, advocacy, and awareness through innovation and innovative programs and services and information that we provide, such as this webinar here tonight. So we appreciate everyone's participation. We'd love to hear from you as part of our community. And if you're interested, we also offer a network of support groups across the country, both community-based support groups as well as some social media-based Facebook support groups as well. So if you're interested in that, if you want to check it out, please let us know. I believe Dan will share a link at some point during our webinar to where you can go for more information or to register or find out more about support groups. But I would encourage everyone to check that out if you haven't already done so. Also want to remind everyone that the Canadian Spondylitis Association is a registered charity. We've been around for quite a number of years, but it's only been about the last year or so that we actually achieved registered charity status. So what that means is we can now issue tax receipts for donations. So if anyone is so inclined, if you'd like to make a donation, a one-time or a monthly donation, any amount is very helpful in helping us do more work. Please consider that and visit our website, and you'll see an easy way to make a donation there, or you can contact any of us by any other method as well. Before I turn it over to Dr. Zumer, I also want to point out and acknowledge our funding partners that we work with. Without the support of these organizations, we would not be able to provide opportunities like this webinar tonight for our community. So we thank these organizations and many other donors and supporters for their support as well. So at this point, I'm going to introduce quickly Dr. Michel Zumer and turn it over to him to carry on with the content for tonight. Just by way of introduction, Dr. Zumer received his MD from Laval, followed by specialty training in internal medicine and rheumatology at the University of Montreal and McGill University. He is associate professor at the University of Montreal and served as chief of rheumatology at Maisonneuve Rosemont Hospital. where he practices as a clinical rheumatologist. He's currently a board member with a number of organizations, including SPARC, the Spondylitis Research Consortium of Canada, and has done some amazing work both in Canada and internationally. He's also been highly decorated, recognized for his accomplishments, including the Canadian Rheumatology Association honoring Dr. Zumer with the Distinguished Rheumatologist Award for Outstanding Contributions to Rheumatology in 2020 with the CRA Master Award. Currently, Dr. Zumer's focus is on improving health care delivery for individuals with rheumatological problems, and his research interests include psoriatic arthritis, spondyloarthritis, and rheumatoid arthritis. So without any further ado, I will now turn the presentation over to you, Dr. Zumer.
Well, thank you very much for the very kind introduction. And I hope we'll be getting back to in-person meetings, because I'd rather speak to individuals and speak to my screen, but here's where we are now. So tonight, the task is to talk about biologics, but I thought I'd see a little bit more of how we make treatment choices. When I say we, I mean we, meaning your rheumatologist and yourselves, because it's a shared decision. So trying to advance. So just start off that typical person that presents in my office, you're 29 years old, you've had low back pain for the last 6 years. Lately, you've had more pain, it wakes you up at night, your back is stiff in the morning, and in the past, you've had x-rays, and the x-rays have always been normal. So you've been to the pharmacy, you've taken over-the-counter medication, Advil, whatever, some glucosamine, you've tried some CBD, helped a little bit, but not in a spectacular fashion. You've gone to walk-in clinics a few times, you've had some non-steroidal anti-inflammatory drugs with some relief, and you've tried different physical therapies that also gave you temporary relief. So eventually you ended up in a rheumatologist's office, and you have a diagnosis of a spondyloarthritis. So this is typical what we see, people that have had low back pain for about 7 to 9 years and eventually get into a rheumatology office where we can make the diagnosis. So the objectives tonight, more specifically, would be to identify the goals of treating the spondyloarthritis and look at the factors which we as rheumatologists consider when discussing treatments for spondyloarthritis and how you would go about making a choice. So I'd like to speak briefly about disease manifestations, goals of treatment overview with the approach we have, the drug classes, and the choice of medications. So as far as disease manifestations, so this is spondyloarthritis. So spondyle is spine, arthritis is inflammation. So usually the main symptom is in the spine, usually starts in the lower spine, and you have pain and stiffness. And you may also have peripheral symptoms, peripheral meaning other joints, for instance, knees, ankles, or wrists. That is common, but not as common as the spine. And then there are related conditions. So about 40 to 50% of people with spondyloarthritis have a related condition. And the three main related conditions are uveitis, so inflammation in the eye, psoriasis, or inflammatory bowel disease like Crohn's or ulcerative colitis. Now, whatever I'm going to talk about tonight, I'm going to talk about the disease as a whole. Doesn't mean that everybody with the disease will have every manifestation, might not have any of the other related conditions, but 50% will have them. And the most common is uveitis. And usually the uveitis will be present before you have a diagnosis of spondyloarthritis. Usually it's self-limited and responds very well to treatment. And then there are comorbidities. So individuals with inflammatory joint disease like spondyloarthritis have a higher incidence, a higher chance of having, for instance, cardiovascular disease, which is a comorbidity. So a higher risk of having heart attacks or strokes if the disease is not treated. Usually when the inflammation of the disease is treated, usually the risk goes back to what would be a normal risk for somebody of your age. So just to be clear about what we're talking about tonight and the terms, because the terms are getting a little bit confused. So talking about spondyloarthritis, so inflammation in the spine. but it's a spectrum of diseases, as you see on the right. So we talk about axial spondyloarthritis, meaning mostly the spine, and radiographic, meaning that we can see changes on X-rays. And this is now known as radiographic axial spondyloarthritis. It is also known as ankylosing spondylitis. So this is what was classically the disease that I learned about when I was a young rheumatologist. And with the advent of other imaging techniques like MRIs, we've realized that there are people that have the same disease, but that the X-rays are normal. So this is called non-radiographic axial spondyloarthritis, where the X-rays will be normal. The disease symptoms are the same. The treatments are exactly the same chances of getting a good response to treatment, but the X-rays are normal. And usually, most often, the disease will be diagnosed using an MRI, so another type of imaging. We also have peripheral spondyloarthritis, where the main symptoms are not in the spine, but more in other joints. For instance, like I mentioned, the knee or the ankle. And the most common one is psoriatic arthritis. But tonight, I'm going to talk mostly about spondyloarthritis, so mostly about disease of the spine. So I said, what is radiographic? Here, this is a pelvis. So you have your lumbar spine, your lower spine, you have your hips over here. And these are the sacroiliac joints. And these are usually the area where the arthritis strikes first. And here we have a normal X-ray. So we can see there are two sacroiliac joints, and there's this dark zone in between the bones, which is cartilage, and this is normal. The cartilage is less dense than a normal bone. Here we have somebody who has sacroiliitis on both sides. You can see the lines are not as bright. It's very irregular. And these are erosions, so they're little bites out of the bone. And when we have individuals that have chronic low back pain, and we have a pelvic X-ray that shows this is enough to give us the diagnosis of ankylosing spondylitis, or as known now, radiographic axial spondyloarthritis. And as the disease progresses, and it doesn't always progress, but can progress, and here we don't see any of these lines, the sacroiliac joints has completely disappeared. So this is complete fusion of the sacroiliac joints, which is not a problem because these are not joints where there's a lot of movement, but usually the pain might even decrease because there is no movement, and there's bone that has grown across the joint and is now fused. We have here a normal spine, so you have your lumbar vertebrae, and with spondyloarthritis, we have syndesmophytes. So this is one of the reasons why the spine will get rigid and less mobile, because between the vertebrae here are little bony growths called syndesmophytes, and they grow and make bridging between the vertebrae, and this can go all the way up the spine. This doesn't happen for everybody, but can happen in a significant number of individuals. So with the X-rays, and even this type of X-ray of the spine, there are not any other diseases really that will give you these type of images on X-rays, and the disease is diagnosed. So here again, we have normal pelvic X-ray with normal sacroiliac joints. And if we strongly suspect a spondyloarthritis and we have normal X-rays, then we'll get an MRI. An MRI is another type of imaging that uses magnetic fields. And here you have the sacroiliac joints. Where the arrows are, where the white is osteitis or inflammation of the bone. And these are changes that also can be quite characteristic of spondyloarthritis. And this person here would have non-radiographic axial spondyloarthritis because the X-ray was normal, but the MRI here is positive. So that is the terminology that we have. So, but like I mentioned at the beginning, what we've noticed and what is noticed after studying the disease now for many, many years is that having either ankylosing spondylitis, which is the radiographic axial spondyloarthritis, or the non-radiographic, where the X-rays are normal and the MRI might be positive, the disease symptoms are the same, as well as the treatment approach. So there really isn't any difference in how we will manage the diseases. But in certain areas, in certain countries, and maybe certain provinces, there would be a difference, and that might have an impact on reimbursement for the medications, for the more expensive medications. That is not the case here in Quebec. So what are the goals of treatment? So when we talk about deciding about a treatment, we always look at the balance between benefit and risk. How beneficial is it to take a certain medication or have a certain type of intervention, and what is the risk? So the benefit of treating spondyloarthritis would be reducing pain, for instance, reducing the stiffness, being able to function normally, be able to work properly, and do whatever you want to do. The risk would be the risk, for instance, of the side effects of giving a medication, or even other types of dangers that could be involved. For instance, if a medication would induce a certain type of disease if it was given. So usually we look at when the benefits outweigh the risk, this we say is a good choice and would be a benefit to try the medication or the intervention. However, if the risk outweighs the benefit, usually we would want to change for another type of intervention or treatment. However, there's also the factor of cost, because something could have a good benefit risk ratio, but the cost could make it not necessarily the first choice. So for instance, for your spondyloarthritis, if I give you a medication A and you're 80% better and it costs, let's say, $100 a month, and there's medication B, which will make you 90% better, but it costs $300 a month, is triple the price or $200 more really worth the benefit of the extra 10% of improvement? Now, this could be something that could be decided by the individual yourself, if you're the one necessarily that are bearing the cost. However, people who pay for these medications, like our insurer, be it the provincial government or private insurer, might decide that the added benefit is not worth the cost. We do this type of analysis in our daily lives every day. But when it's not us that is paying, then other people might be deciding whether something is of benefit based on the incremental cost. So what are the goals of treatment? Obviously is improving symptoms. When individuals come to see a rheumatologist, they say, well, I got pain, I got stiffness, I have trouble functioning, so improving the symptoms. So we like to focus, and patients like to focus on improving the pain, decreasing the stiffness in the spine, and improving fatigue. Fatigue is often quite a common symptom of disease, which is sometimes directly related to the disease, but sometimes there could be other factors involved. The pain and the stiffness, we usually do quite well with our medications. The fatigue is a little bit harder to manage, and probably also because there are other factors involved than just treating the inflammation of the disease. We want to improve function. So for instance, if there's a certain type of activity, be it sports, work, social activity that you like to do, but you're not able to do because of your arthritis, the goal would be to improve function. We want to prevent ankylosis. Ankylosis is fusion of the spine, so decreased mobility, which can have an impact on your lower spine, but can also have an impact on your neck, on your cervical spine, where it'll be hard to look both ways and give you sometimes difficulty in driving, looking out on your dead angles. So what we've noticed over the years, and this comes from a study in Germany where they looked at about 150 individuals. So on the x-axis here is the duration of disease. So they looked at individuals who had with this here was ankylosing spondylitis that lasted up to about 45 years. And they looked at the MSAS. So MSAS goes from 0 to 72 and measures the degree of fusion of the spine. So what they noticed was that there are individuals who had disease that went up all the way to 40 years that had a normal spine basically on x-ray, so no loss of mobility. However, there are individuals who progress quite rapidly, and this independent of when along their disease course they were. So you could be early on in disease and progress rapidly, and you can be later on and progress rapidly. Unfortunately, we don't have very good indicators of who's going to be in the group that doesn't progress and who's in the group that will progress. And the studies to find medications that'll prevent fusion of the spine are very difficult because changes happen very slowly, and there are studies that would take a long time to do. So as of now, we have medications that are indicated or approved for improving symptoms and function, but nothing really that will prevent ankylosis, even though we have a very good idea that medications like biologic medications will prevent ankylosing or fusion of the spine, but we don't have the studies that actually prove it. But in certain types of observation, we've seen that up to now. Now, also, I talked about your related conditions. So psoriasis, uveitis, or Crohn's disease, or ulcerative colitis. So the goal of treatment is, if you have a related condition, to treat both diseases, and often we can do both diseases with the same medication. And again, the comorbidities, of which the most frequent is cardiovascular disease. Usually when the disease is treated, when the inflammation is reduced, the comorbidities are taken care of as well. So looking on to treatment overview. So obviously the first line of treatment are non-pharmaceutical interventions. Weight, for people that are overweight, weight loss has been shown to improve the symptoms and also have helped in response to medications. So losing weight, or people that had a normal body weight as opposed to people that were overweight, responded better to treatment. The drugs were better in people that had a normal weight. So weight reduction is always strongly advised. Smoking cessation, again, smoking decreases the ability of medications to give you a good response. So stop smoking, you have better chance that the drugs that you're taking will be working. Also, because disease can affect the ribs and your breathing patterns, smoking is not good for lung function, and you'll preserve your lung function and have less trouble breathing. Exercise, physiotherapy is very important, as well as sometimes access to other healthcare professionals. For instance, social workers, dietitians, occupational therapists can always help if there are adjustments to make in your disease. Surgery is very, very rarely used in spondyloarthritis. There's no good surgery for the spine in this disease. Individuals who benefit the most are a small percentage of individuals who have inflammation in the hip joints, and often the hip joints have to be operated on because they will become damaged during the course of the disease. This is a minority of people, but that could happen. And then there are medications, of which is the main object of the discussion tonight. So what are the drug classes? So we have analgesics. We say simple analgesics. So these are medications that relieve pain. So acetaminophen is the one that is best known. Tylenol can relieve your pain. Antidepressants are sometimes used, not for their antidepressant function, but because antidepressants also work as pain relievers. And then there are neuromodulators like pregabalin or gabapentin, Lyrica or Neurontin that can help for pain. Opiates are very, very rarely used for spondyloarthritis. They're not very effective, but they are pain medications. And then there's injections. If you have a joint that's inflamed, you could have a cortisone injection. If, for instance, individuals can have one sacroiliac joints that's very painful, the sacroiliac joints can be injected as well. Often during pregnancy, the sacroiliitis can get worse in pregnant women, and very often will have the sacroiliac joints injected. The injections are cortisone injections most often. Cortisone by mouth is not used for spondyloarthritis. Now, the main drug classes that have indications or that are effective in spondyloarthritis, the first class are non-steroidal anti-inflammatory drugs, for instance, naproxen, indomethacin, Voltaren. There are a whole slew of them. So non-steroidal anti-inflammatory drugs used properly give excellent results in about 50 to 70% of individuals with spondyloarthritis, and these individuals will not need any other medications for the disease. The thing about non-steroidal anti-inflammatory drugs is that when they're used at lower doses and used sporadically, not on a regular basis, they can relieve the pain, but they do not decrease the inflammation. So non-steroidal anti-inflammatory drugs should be used at anti-inflammatory doses. So that is maximum dose every day to have a very good effect on the inflammation, on the symptoms and the stiffness of spondyloarthritis. Now, there are some individuals who have very fluctuating disease where you'll have periods where it's very painful and stiff, you'll take your anti-inflammatories during that time, and then we'll have periods where there's a lot less pain, manageable with less doses of anti-inflammatory drugs or no anti-inflammatory drugs. As of now, we don't have any hard proof that taking the non-steroidal anti-inflammatory drugs regularly at anti-inflammatory doses will prevent ankylosis, so fusion of the spine, but there is some evidence that it might. So we can't sort of recommend it 100%, but if you are having symptoms, you should be taking your anti-inflammatories at anti-inflammatory doses. So in the last 22 years have been revolutionary in rheumatology for all our inflammatory diseases, because it's been since 2000 that we've had TNF inhibitors. So we have biologic drugs. Here I put down 3 classes of biologic drugs. There are TNF inhibitors, Il17 inhibitors that are both used in spondyloarthritis. Il23 inhibitors, I just put it down because they're very effective for psoriatic arthritis, not for spondyloarthritis. Il23 inhibitors do not work on the spine in spondyloarthritis. They might be effective in the spine for people who have psoriatic arthritis with inflammation in the spine. Now they're called biologic drugs because they are produced in a biologic system. So they're produced in cells. So cells are little factories that produce antibodies. These inhibitors are antibodies against molecules that are responsible for inflammation. So TNF is tumor necrosis factor. So TNF inhibitors inhibit tumor necrosis factor, and IL-17 inhibits another molecule that is important in development of spondyloarthritis, IL-17. We also have small molecules that are called JAK inhibitors. So these are chemicals. They're used now for psoriatic arthritis, but do not have approval yet for spondyloarthritis. So, and all these drugs, the TNF inhibitors, IL-27 inhibitors, they're equally effective in treating the signs and the symptoms of spondyloarthritis. So what are the TNF inhibitors? So we have 5 TNF inhibitors that have been around. The first 3 that have really been around since 2000. The others that have come on a little bit later, but most of them have been around for at least 15 years. All except infliximab Remicade are given by self-injection, usually with a pen, like a diabetic will. What's different is maybe the frequency of injection. Etanercept is injected once a week, adalimumab every other week, golimumab every month. Infliximab is given in an intravenous infusion, so you have to go to an infusion center, and usually the infusions are once every 8 weeks. So some people will prefer self-injection. Most people prefer self-injection. Some people will prefer intravenous. So since the advent of biologic medications, obviously the use of these medications has increased considerably. So looking here, these are statistics from Canada, from Health Canada, looking at how much of the drug budget goes to biologics. So in 2011, it was about $3 billion. And in 2020, it tripled up to $10 billion, which is now about a third of the budget of all the drugs that are sold in Canada. If you look at the per capita, in 2011, it was $96 per Canadian, and now it's $262 per Canadian. So one way of trying to control the cost is to produce biosimilars. So biosimilars are the same medication as the original drugs that you see here, Enbrel, Remicade, and Humira, when they come off patent, and there are other companies that will produce them. They are not identical because they're produced usually in different cell systems. Remember, I said biologics are produced by living cells. And since these are proprietary, the companies can know the structure of the molecule. So the molecule is the same, but where it's grown and what type of cell it's grown is different. So they might have small differences in the little bits of sugars that are added to the medication, but in essence, and to be approved as a biosimilar, the medication, the biosimilar has to be just as effective as the original drug. So the etanercept biosimilar is just as effective as the Enbrel original drug. So the reason for biosimilars, just a little bit like generic drugs, but generic drugs are pretty much identical medications. Biosimilars have that little difference, but in all intents and purposes, they're the same. So what are the biosimilars? So biosimilars, we have 2 biosimilars for Enbrel, etanercept, Brenzys, and Erelzi. We have 4 biosimilars for infliximab, and we have 8 biosimilars for adalimumab, Humira. And that's because Humira has been the drug that has been the biggest drug sold in the world. So once it's come off patent, there were many companies that have gone to produce biosimilars. Now, all these biosimilars, as well as the originator, the original drug, all have equal efficacy. It's just a matter of cost. So as you might know, in Quebec, following other provinces, BC was the first. In Quebec, between April 2001 and just recently, April 2022, anybody who was under had the provincial insurance was switched from the original drug to a biosimilar, and because the insurer, which is the Quebec government, said they will not pay for the original medication anymore. And usually the biosimilars are about 2/3 the price of the original medication. So we've just finished transitioning, we call that transitioning our patients from the original drug to the biosimilar. And the private insurers, for the most part, have followed suit, except they only gave us a month or two, in the last month or two, to do it. And by now, most patients will be on a biosimilar. So that's for the TNF inhibitors. We also have Il17 inhibitors. So these target the molecule Il17. And there are 2. There's secukinumab, Cosentyx, and izokizumab, Taltz. So secukinumab is the only Il-17 for spondyloarthritis that's paid for by the provincial government in Quebec. Izokizumab is not, but it's paid for by the private insurers. I said we have IL-23 inhibitors. I put them here just in case you recognize the names, Tremfya and Skyrizi. And so these are used for psoriasis. They've been approved for psoriasis. They have excellent response for psoriasis and are very safe medication. They have just been approved for psoriatic arthritis, but they will not be approved for spondyloarthritis. And I say we have small molecules. We have tofacitinib, which we've had now for about 7-8 years for psoriatic arthritis, and upadacitinib, Rinvoq, that has been approved for psoriatic arthritis recently. And upadacitinib, Rinvoq will be approved probably in the next year or so for spondyloarthritis. It's just been approved for spondyloarthritis in the USA by the FDA. So these are the medications that we have available as biologics for treating spondyloarthritis. So how do we choose? So when we look at the algorithm of how we treat disease, the mainstone, the cornerstone, again, is education, exercise, physiotherapy, associations like this. The self-help groups have been mentioned in the chat as well. Like I said, smoking cessation, ideal weight, having a good diet is very, very important. First drugs that we use are non-steroidal anti-inflammatory drugs because they are effective, and they're extremely effective in 50 to 70% of individuals. They're low cost, and usually they're very well tolerated in people with spondyloarthritis. However, certain individuals will not tolerate them very well. When the non-steroidal anti-inflammatory drugs are not effective, then we go on to biologic DMARD, so Tnf inhibitors or IL-17 inhibitors, and no other medications really in between, unless we have some mainly peripheral disease. But for tonight's purposes, we'll talk about basically NSAIDs, and with failure of NSAIDs, it would be TNF inhibitor or IL-17 inhibitor, and they're the 2 biologic DMARD is disease-modifying anti-rheumatic drug. They're both equally effective for treating the arthritis in people with spondyloarthritis. Analgesics in surgery. Analgesic could be used as an add-on for pain because often you may have pain that's not necessarily associated with your spondyloarthritis. The inflammation is being well controlled, but you might have had some osteoarthritis in your lower spine as well. So this brings me up to reimbursement criteria for Quebec. So not only do we know that if you take anti-inflammatory medication and the anti-inflammatory medications are not effective, then you can receive a biologic medication, but because of the cost, there are reimbursement criteria. So these are drugs, special medications that have a special process for reimbursement. And this is true, what I'm going to be telling you for the provincial government, but it's also true for the most part for the private insurers. In Quebec, we're really lucky as far as the population because everybody has drug insurance in Quebec. So everybody should be able to be treated appropriately for their disease. So what are the criteria? So you have to have a BASDI. So this is a BAF ankylosing spondylitis disease activity index, which is greater than 4. I will show you it's a questionnaire. And you will have had to take in 2 anti-inflammatory medications. So be it, for instance, naproxen and Terran. Also, over-the-counter medication can count. So, for instance, over-the-counter Advil could count as well. And they should be tried for 3 months. So 3 months is a long time. Usually we'll know if an anti-inflammatory medication will work within a month, but the government criteria and a lot of the private insurance criteria is that you'll have to try 2 anti-inflammatory medications for 3 months each. So we're looking at 6 months. And unless there's a contraindication, a reason why you cannot take non-steroidal anti-inflammatory drugs, for instance, somebody that has an active ulcer will not be given an anti-inflammatory medication. So, and then you have to show an improvement at 5 months. So you have to be reevaluated by your rheumatologist or the person that prescribed you the medication and have an improvement. The improvement is here. It's basically an improvement about 50% in your symptoms or function or a return to work for people that were not up to work. And then the provincial criteria, you have to be evaluated every year and prove that the medication is still working. So the private insurers sometimes will give you a lifetime approval and you'll not have to be reassessed. But for people that are insured by the provincial government, you'll need to be reassessed every 12 months to continue receiving reimbursement for the medication. So this is the BASDI. So Bath is a city in the UK. That's where it comes from. And there are 6 questions looking at fatigue, pain, and symptoms of inflammation on a score of 0 to 10. Then we add them all up and divide, and the scale goes from 0 to 10. Like I said, if you have 4 or over, then you are eligible to receive a biologic medication or reimbursement for a biologic medication. If you don't have 4, if you have less than 4, the government will refuse you, and most private insurers will refuse you unless there's a very good explanation. And again, to show improvement, you have to show an improvement in your BASDI of about 50%. The BASFI, which is the BAF ankylosing spondylitis functional index, so this is more a function of what you can do, are 10 questions, and here are the questions. Right? And again, it's on a scale from 0 to 10. And again, we're looking at an improvement of about 50% in the BASFI. So you could have an improvement of either in your BASDI, your disease activity index, or your BASFI or BAF functional index, about 50%, or return to work, then continue to receive reimbursement for your medication. So how do we choose which one? Well, we look at efficacy. So efficacy is how well the medication works. So what is important is pain, stiffness, fatigue, leisure activities, whatever. But for a drug to be approved for spondyloarthritis, up till now, a lot of it has been using the ASAS and more recently the ASTAS. So what are these? The ASAS is a questionnaire, 4 questions, and you have to show an improvement of 20 or 40%, depending on what is required by the regulators. So usually a study is done. It'll last 6 months or a year, depending on if it's FDA or Health Canada. And usually it'll be receiving the medication compared to either placebo. Placebo maximum now is 3 months because it's unethical to not treat people. And more it's becoming unethical to use placebos in these studies. And usually you'll maybe comparing it to an existing drug. So for instance, when the newer drugs, the Il17 inhibitors were studied, very often they were compared to a Tnf inhibitor and to compare to see if it's just as efficacious or more or less, because it was unethical to use a placebo. The ASDAS is basically the same type of questionnaire, but includes a blood test for inflammation, and this gives some a little bit more information. Not only do we have the symptoms, but we see if there's any inflammation in your blood. And about 50% of individuals with spondyloarthritis will have a high sedimentation rate or a high CRP. Sedimentation we do very little of now. We do mostly CRPs. So we look at efficacy, and once a drug is approved, doesn't mean we stop studying it, because not only do they look at efficacy in the studies, they also look at safety. Safety is very important. And then we study patients for the duration of the disease for a lot of patients. For instance, at the beginning, you mentioned that I was part of SPARC, the Spondylitis Research Consortium of Canada. So we have patients in a database. We have thousands of patients across Canada that we evaluate once a year to see how the disease goes, and we know what medications they're taking, what type of side effects, what other types of issues there are. And it's another way of studying to see if the medication is still efficacious, how long you'll take it, if it loses effect, and how safe it is, if you have any problems. For instance, an adverse event or a problem that we had some fears of at the beginning that have been now proven wrong with TNF inhibitors, we thought they might cause cancer. So for the most part, they do not. And that we've been able to study over the period of about 10 to 20 years, which is hard to study in a study that's only, like, for instance, 3, 6, or 12 months. So first we look at efficacy. So for non-steroidal anti-inflammatory medications, we know there's efficacy, and it's a first choice because of reimbursement issues. Nothing stops you from being prescribed a biologic medication right off, but you'll have to pay out of pocket. Nobody's going to reimburse you for it unless there are contraindications. So are there contraindications to anti-inflammatory drugs? For instance, if you have active inflammatory bowel disease, Crohn's or ulcerative colitis, that is a contraindication to receiving an anti-inflammatory medication. If you've had a hemorrhage from your stomach, so a bleed from your stomach because of anti-inflammatory medications, that would be a contraindication. If you have multiple sclerosis, you should not be getting a TNF inhibitor because there is an increase in the risk of having a flare of your multiple sclerosis if you receive a TNF inhibitor. So we will give an IL-17 inhibitor. Some medications like TNF inhibitors work well for spondyloarthritis, uveitis, inflammatory bowel disease, and psoriasis, and it's a good choice. However, IL-17 inhibitors will not work for inflammatory bowel disease, but are really good and better than TNF inhibitors for psoriasis. So there are different ways of balancing which medication will be chosen. Again, so I spoke about related pregnancy. So we have a lot of very, very good data now with TNF inhibitors in pregnancy, that they are safe in pregnancy and they're safe for nursing mothers. So it's a discussion between the rheumatologist and the patient whether the TNF inhibitor will be stopped during pregnancy. Some patients know that if they stop TNF inhibitors for 2 or 3 days, their symptoms can go back to where they were before and are non-functioning and will continue their TNF inhibitors. Other individuals might get away with not taking the TNF inhibitor, but that might have to start it during the pregnancy. But IL-17 inhibitors, we have very little, if any, safety data in pregnancy, and we will choose more often a TNF inhibitor in a potential mother over an Il-17 inhibitor. Then there's the route and frequency of injection. Some people prefer to receive intravenous and not have to worry about it, go once every 8 weeks to a perfusion center. Other people will prefer to self-inject themselves. Some people prefer once a week. They feel better once a week. Some people feel better once a month or once every 2 weeks, depending on the medication. So that's a personal choice that the individual can make. Then again, there's coverage and cost. Like I said, in Quebec, we're lucky. Everybody's covered. The cost issue is similar for all the medications. Usually if you're on a biologic medication, you'll hit your ceiling. So cost will not be a major decider. But for people that live in other provinces that don't have the same kind of coverage, and cost is definitely an issue. Now, coverage could be an issue as well eventually, where governments, and in some provinces, medications are tiered, which means you might have to take a certain medication over another. For instance, you might have to take a biosimilar TNF inhibitor over a brand like, for instance, Symphony, which is golimumab, that does not have a biosimilar. In Quebec, we can prescribe the original where there's no biosimilar, but if you're going to give a drug that has a biosimilar, you give the biosimilar. In other provinces, you can only give the drug that has a biosimilar before trying the drugs that are more expensive. And then there's the patient program. So every medication, biologic medication, has a patient program, which is an arm's length company that manages the reimbursement side of the biologic medication, because it is a process to get reimbursement. Those of you that have been in the process, you know that it doesn't always work in a very fluid fashion. So patient programs help, and they're usually the intermediary between you, your physician, and the insurer to try to get coverage or to ensure coverage. And a lot of the patient programs also provide other services. They might provide blood tests, and they do help with copay for people that need it. So if you cannot handle your copay, the cost of the medication, all the programs, or almost all the programs, do provide financial support. Now, this was in jeopardy of being lost last year in Quebec because of government regulation. It hasn't, but it might become an issue in the future. On our side, as physicians, we have to deal with the patient programs. As you saw when I showed you a list of biosimilars, there are many companies. Some programs on our end work a lot better than others. So your rheumatologist might prefer to work with a specific patient or several patient programs where there's good communication, and we know that it's easy for you to get your coverage and get your copays and everything, and other companies which are more difficult. We had an issue with one company last year that made it very difficult for our patients. So sometimes if there are, for instance, 8 adalimumab biosimilars, we might prefer 1 or 2 that we really have a much better communication with to help you get reimbursement. They will also sometimes help to provide the medication before you get approval if you do have the criteria to meet the criteria, because sometimes the paperwork could take about a month or 2. So we also, when we're choosing medication, we look at side effects, potential side effects. So individuals who've taken anti-inflammatory medications that cannot tolerate them, obviously, we will try to, it would be a reason to go to a biologic medication. Adverse events, again, if you've had a complication of a type of medication, that's not the type of medication that will give you. Vaccination is very important. So if you've had infections in the face, we want to make sure that your vaccine status is up to date for all the normal vaccines. And we do screen for infections. We screen for hepatitis, we screen for hepatitis B, hepatitis C, we screen for HIV, and we screen for tuberculosis as well as other infections. And that's because biologic medications, mostly TNF inhibitors, can reactivate a disease that you've had, and sometimes you don't even know you've had it, and it can reactivate it. Just in the last couple of weeks, because we screen people for tuberculosis, I've had 2 patients that I wanted to start biologic medication on, and their test for TB came back positive. So they do not have active TB. They have what we call latent TB. That means they probably had an infection. Sometimes it could have just felt like a lung infection or pneumonia, and that cured, and the bacteria stays dormant in the lung and will stay dormant forever unless we give something that will help it develop into an infection, and that would be a TNF inhibitor. It's not a problem once we discover that it's latent TB. You get a treatment with an anti-TB medication. Right now, we could do 4 months of treatment, and we can usually start the TNF inhibitor at the same time, or some people wait a month after the anti-TB medication to start your biologic. So we've looked at the benefit and risk of medication. Benefit, relieving your pain, your stiffness, making you function normally. So the goal is for you to have a normal life, but very often you need medication. So what happens after that? So if this is what we have to do on our side is apply for reimbursement. This is the Quebec reimbursement for an anti-TNF medication. We have private insurers. The problem is that private insurers, each insurer has different forms. We've been working now for many years on the national level to try to get one standardized form for all the private insurers. That's still a work in progress. So this is what your rheumatologist has to fill out. Identifiers, the medication, is it an initial request, is it a renewal, what's your disease, and then your BASDI and BASFI scores, as well as what medication you've taken and why they haven't worked. And then once you're on the medication, after 5 months, fill this out again and give the original scores and show the improvement. And then yearly, we have to fill this out. Usually we'll do this, we'll fill this out. And if you're enrolled in a patient program, we'll send this off to the patient program, who is supposed to be the ones that take care of getting reimbursement either from the provincial government or from the private insurer. So what happens after that? So you're taking your medication, you've been on the anti-inflammatories, they've lost effect or they're not as good. Now you're on a biologic medication, you can have pain that comes back. Very often it's adherence problem. That means you've stopped taking your medication, or you're not taking your medication properly, you're skipping doses or whatever. So very often when people are feeling really great, they'll stop their medication, or there are other reasons why you might stop your medication. Sometimes you have no choice. For instance, if you go to surgery, you'll have to stop your medication. So one of the reasons you might have increases, you're not taking your medication. There may be other causes for symptoms. If you have lower back pain, you can have low back pain because of your spondyloarthritis, but there's a significant percentage of individuals with spondyloarthritis that also have disc disease or osteoarthritis in your spine. You might have a vertebral fracture if you have osteoporosis. So you have to make sure that there's nothing else that is causing your symptoms before we think of changing your medication and saying that the drug just does not work. There's disease fluctuation. Not everybody has pain and stiffness continuously. Some people have disease that fluctuates. They'll get better, they'll get worse, depending on different factors. So that might be a reason why you might have increased symptoms. At that point, we might change your anti-inflammatory medication for a short period, and then you'll recapture the efficacy of your medication. And then there really is loss of efficacy. And very often, the biologic medication will work in about 80% of individuals when we start. So 20% will not have a very good response. That's called primary loss of efficacy, so it never worked. We will change classes. So if you were on a TNF inhibitor, we will change it for an Il17 inhibitor. But sometimes after a year, 2 years, 3 years, the drug will lose its effect for different reasons. And then when we look at our data, for instance, in Spark, and this is true in a lot of countries, about 50% of individuals will lose some, if not all, of the efficacy of their medication in about 5 to 7 years. And at that point, we can change medication. If, for instance, you were on a certain type of medication, for instance, a TNF inhibitor, and you've on it for 5 or 6 years and you're already losing some effect of the medication, we might try another TNF inhibitor because it's worked, its lost effect might have something to do with the individual medication. Or we might decide to change class of medication. So in conclusion, spondyloarthritis is a chronic disease with no cure. We're not close to cure, but we're heading that way. There's research that's being done, and hopefully people will support the research in Canada. We have very effective medications. The advent of biologic medications has really changed the way our patients can function and be pain-free, but it doesn't work at 100%, but there are more medications to come. As mentioned before, the JAK inhibitors, certainly Rinvoq, upadacitinib, will be the next new medication for spondyloarthritis and will probably be approved in the next year or two. Treatment goals are symptom relief and possibly disease modification. We don't have hard proof yet. We do have enough suggestions to show that taking an anti-TNF inhibitor will slow down or stop progression of ankylosis in the spine and probably will be proven. Those studies are underway. As I said, they're very hard to do and they have to be very long-term. If I compare it to a disease like rheumatoid arthritis, where we can show significant disease inhibition in 6 to 12 months, we can't see it in spondyloarthritis before studying the drug for at least 4 years. So we cannot make a difference before 4 years of studying the drug. So that's what makes it a lot more difficult. And non-medication interventions impact response to your treatment. Certainly weight loss is important if you're overweight. Smoking, stop smoking if you're stopping smoking. And certainly physiotherapy and doing your exercises have been shown to be very effective in helping relieve your symptoms of spondyloarthritis. Choice always involves weighing the benefits and the risks, but also involves personal factors. For some reason, you might prefer to have one type of medication over the other for whatever reason, and certainly you do have a choice in that when presented with the various options, and cost is always a factor, and very often the cost issue is decided by the payer for the more expensive drugs. So that's about it, and I think we got a few questions to come.
Yes, we do. Thanks, Dr. Zumer. Thank you very much. That was fantastic, and I'll give you a chance to catch your breath here. Just mention that we did start a little bit later than we had hoped to because of technical Zoom issues. So we are going to stay on a bit longer for those that are able to. And thank you for Dr. Zumer for that incredibly informative presentation. We really appreciate that. I think some of the questions may have been addressed through your presentation, but would you prefer that I feed questions to you?
Yeah.
Or do you want to
why don't you give me questions, Jeff? That'll be really
okay, sure. Okay, so the first one is, with the increased chance of infection while using biologics, do the benefits outweigh possible illness and complications?
Okay, so biologics on the whole will increase your risk of infection, but there are a lot of factors that increase your risk of infection. One of it is disease. So when we look at medications that increase risk of infection, for instance, TNF inhibitors, where we see a big difference is in people with rheumatoid arthritis. That's the highest risk. People with psoriatic arthritis, a little bit lower. People with spondyloarthritis have very, very low risk of infection, which is almost no risk of infection because usually our patients are younger and don't have other diseases. For instance, other diseases that will increase your risk of infection are diabetes or COPD. So, bronchitis, emphysema, and certainly if you've had infections in the past, and cortisone. So cortisone is not used in spondyloarthritis. It's used not that often, but often enough in rheumatoid arthritis. So on the whole, these medications increase the risk of infection. But when we look at the same medication over the three diseases, rheumatoid arthritis, psoriatic arthritis, spondyloarthritis, very often the risk in spondyloarthritis is almost zero increased if there are no other factors. Smoking also is another factor that can increase the risk of infection. So if you are a healthy person that only has spondyloarthritis, and are on biologic medication and have a tendency for infections, normally you should not have a problem, but you should have your vaccines up to date.
Okay, thank you. We're going to try to fly through. I don't think we'll be able to get to all the questions. We have quite a few that have come in, but we'll try to get to as many as we can in the next 10 minutes or so. And for those that we haven't answered, we'll keep a record of them, and maybe we can send out some information to try to address some of those after the fact. But you had mentioned during your presentation that antidepressants are used from time to time, and the question is, which antidepressants work as analgesics?
Well, most of them work as analgesics. A lot of duloxetine is used, quite a bit because it does have an approval for low back pain. So citalopram and duloxetine. I personally don't use a lot of it, but those are the ones that are used the most. They're most effective. However, it's mainly an issue of side effects that will limit the choice more than the actual medication as far as efficacy.
Okay, thank you. Next question is, someone says their physiotherapist is recommending Synvisc injections, and just wondering if you have any information about that.
Synvisc is hyaluronic acid, which is used for osteoarthritis. No use in spondyloarthritis unless you have osteoarthritis because you've had damage of the joint.
Okay, thank you. Is one class of biologics more effective at treating enthesitis?
Normally, we think the Tnf inhibitors and the Il17 inhibitors are equally effective. We have a little bit better data for the Il17 inhibitors, and because it also makes more sense in the pathophysiology of the disease, because it's a molecule that's more closely associated with the enthesis when we look at how diseases develop. And some people might feel that Il-17 inhibitors will be a little bit more effective in enthesitis. If people have a lot of enthesitis and maybe psoriasis, then we might have more tendency to go with an Il-17 inhibitor.
Okay, thank you. Is it common to have to stay on methotrexate when you move to a biologic medication?
Okay, so methotrexate is used for peripheral disease, so arthritis in the joints like knee, ankle, wrist. Its use in spondyloarthritis is a lot less than in rheumatoid arthritis or psoriatic arthritis. So if we're talking about straight spondyloarthritis, the only place really would be either you have peripheral disease or there's evidence that taking a TNF inhibitor, a monoclonal antibody, so all the TNF inhibitors except NREL or etanercept, it'll decrease the risk of losing efficacy. Because for those type of molecules, so like golimumab Humira, golimumab Simponi, certolizumab Cimzia, over time, your body can form antibodies against the medication, and the medication will lose its efficacy. The methotrexate will decrease the formation of these antibodies, so might increase the amount of time you'll be on the drug before you lose efficacy, but will not work for the disease. However, in psoriatic arthritis, it works for the disease and it prolongs the efficacy of the medication.
Okay, thank you. Question about do biologics help with degeneration of joints in the future, and what happens when you stop taking a biologic?
So biologics for peripheral disease, for instance, like I said, knees, ankles, wrists, have been proven to prevent damage of the joint. Usually we don't stop them. We'll only stop them if you go into remission. So remission means zero inflammation. If you have no inflammation, you will not damage your joints. The chances of going into remission are like maybe 5 to 10%. Very, very, very rare that you can have what we call drug-free remission. It means remission without any medication. So sometimes if one of my patients has been on a biologic medication for many years and has been without any disease activity for a year to 2 years, and I might want to do something like an ultrasound of the joint or another MRI of the spine to make sure they're in remission, we might try to wean them off. But usually about 3/4 of the people that we wean off biologic medication will flare again. So it's not, usually it's a life, as of now, we have no cure. So you better consider it a lifelong medication.
Right. Question about peripheral neuropathy as a side effect from TNF inhibitors. What percentage, how prevalent would that be for people?
If you're prone to MS, you can get neuropathy. So peripheral neuropathy is not really a complication of TNF inhibition unless you're predisposed to neuropathic disease.
Okay. We've had a few questions about efficacy over time. I think you've covered that. Is the JAK class of drugs effective for enthesitis?
In the studies, it's effective against enthesitis, yes.
Okay.
And we use it in psoriatic arthritis, where there's a lot of enthesitis.
Okay, thank you. How safe is it to take biologics during COVID if you are over 65 years of age?
Okay, it's not safe because you're over 65, but the TNF inhibitors and IL-17 inhibitors have not shown any increase in risk for COVID. So you're not at any greater risk because of the medication. You're not at any greater risk of complications if you do get COVID. So TNF inhibitors and IL-17, and the vaccines work just as well in people with who receive TNF inhibitors and IL-17 inhibitors, and are strongly recommended to get.
Okay, thank you. Now I'm going to read this next question. Is a bit lengthy, but I think it covers some points that a lot of people have questions about. So the person writes in, being in my 30s, I'm terrified to take the plunge and proceed with biologics despite recommendations from their healthcare team. I'm afraid of the bleak side effects and worry that my life will be shortened or further complicated due to decades of using, as this person describes, daunting meds. Having AS and psoriatic arthritis, I have one doctor who wants to prescribe TNF inhibitor, one who wants me to use IL-17, and all of this uncertainty is basically caused this person to avoid making a decision. So you did mention a bit about side effects, and that cancer, which is obviously a concern, has been disproven. But do you have any information about long-term use and risks? And also for people that are dealing with both spondyloarthritis and psoriatic arthritis.
Yeah, okay, so I look at the risk of medication, I look at the risk of disease. The risk of medications long-term is basically infection, and usually they're well treated. IL-17 can give you a little bit of candida, like yeast infection in your mouth, which is usually very well treated, and normally you don't stop medication. So we have TNF inhibitors we've been using now for over 20 years. So long-term, no. IL-17 we've had for maybe 7, 8, 9 years now. Long-term, we haven't seen anything real. But what we do know is that if you leave your inflammatory joint disease unchecked, the risk of complications from your disease will far outweigh the risk of taking a medication. I mentioned not only the joint disease, but also in psoriatic arthritis, especially, we have good studies now that you are at increased risk of cardiovascular disease. And you have the same risk as a diabetic of having heart disease and stroke. So, and knowing that treating your psoriatic arthritis will decrease the inflammation and will decrease your risk. So, sure, I'm a physician. I'm going to recommend medication. I know that, but I know what disease does. And I practiced for about 15 years before biologics. And we saw our patients die young, crippled, in wheelchairs. Our waiting rooms were full of wheelchairs, whatever. So they really are good drugs. They're not without risk. Everything's got a risk. But certainly the risks of disease far outweigh the risks of medication or the risk of not treating the disease.
Great, thank you. Do you have time for a few more questions?
Yeah, go ahead.
Okay, I'm trying to skim through here. We don't have time to address some of the more specific ones, but as I mentioned, for those that have more specific questions, please, we're keeping a record of this. Please send them in, and we'll try and connect you with some answers as well. But one question that someone said was, can you touch on how biologics impact the immune system?
Okay, so biologics are very specific, it's quite surgical because TNF will inhibit directly TNF. Il-17 inhibitor directly inhibit Il-17 inhibitor. It inhibits that molecule, but it also inhibit molecules that depend on either Il-17 or TNF to promote activity of other molecules. So we're talking about immunomodulation, not immunosuppression, where part of your immune system is overworked and part of it is underworked, and we're trying to rebalance it. So it doesn't cut it out. There's a lot of redundancy in the immune system. So when we suppress one part of your immune system, there's other parts of your other immune system that come and help out and upregulate and help with immune function. So we don't knock it out. It's not like chemotherapy where we knock out cells and it's more of a across the board thing. It's very specific. It does slightly increase your risk of infection, but it's not like knocking out your immune system completely. So like I said, when we have good data now on COVID, for instance, where people on TNF or IL-17 inhibitors don't have an increased risk of disease or complications. So, I mean, that's a good proof that they're not as immunosuppressive as, immunosuppression is a spectrum, and people think that, you're immunosuppressed or not, but it's actually quite a spectrum.
Right, thank you. Question about, for those who are pregnant or trying to conceive, is there one biologic or another that might be used more specifically for people in that situation?
Yeah, so like I mentioned, we don't have good data on IL-17 inhibitors. We do not suggest IL-17 inhibitor. JAK inhibitors is the same thing when we give a JAK inhibitor. So it's TNF inhibitors. So there's one TNF, they're all safe, and they're all safe in pregnancy and in breastfeeding. However, there's certolizumab Cimzia, because of the way the molecule is made, it's a bit different, and it does not cross the placenta. So we have very good evidence. The others don't cross much, but they do cross a bit. So it crosses the placenta. So Cimzia does not. So if I was starting a TNF inhibitor in somebody that wants to become pregnant or that's pregnant, I might consider a little bit more, but it would definitely be one of the TNF classes.
Okay, thank you. We had a few questions here from people who have been diagnosed with psoriatic and spondyloarthritis, and wondering, which class of biologics might be most effective for people in that situation.
So TNF and IL-17 inhibitors work equally well in the joints, in the spine. IL-17 inhibitors work better for psoriasis. So if you have a lot of psoriasis, if your psoriasis is very active, I would tend to use an IL-17 inhibitor, unless you have active inflammatory bowel disease, but they don't always coexist. But if you have, not that much psoriasis, then either one would be good. But if you have a predominance of psoriasis, if that's the issue, the IL-17 inhibitors are a lot more effective for the skin.
Thank you. Just again, skimming through questions, there's lots of them that we're not going to have time to get to, unfortunately. But one interesting question that I see here is related to the pandemic. Someone says they're a patient program nurse, actually, and that they get questions about patients worried to start therapy due to the pandemic. Is that something that you would advise people on as far as having concerns about that at this point in the pandemic?
Like I said, make sure you're vaccinated and start the medication. Like I said, we don't see any increased risk with these medications. So go ahead, get vaccinated and start. And I wouldn't wait till you're fully vaccinated to start the medication. Depends on your symptoms, but there's no medical reason to wait.
Right. Okay, well, I think we're going to have to cut it off here. We've gone a bit over our allotted time, but there's still some unanswered questions, which I think means we have more work to do in terms of trying to address some of those questions. And we hope to be able to have you back again, Dr. Zumer, to maybe address some of the questions that we didn't get to tonight. But you did cover a lot of ground, and we thank you so much for that. And as I mentioned earlier, this session has been recorded. We will be sending out a link to all those who registered for the session, both those that are here as well as those that registered but could not attend. And we also, just before we close, I want to mention that Dr. Zumer will be delivering this basically identical presentation in French next Wednesday, May 18th, also at 7:30 Eastern Daylight Time. So if you're French speaking, or if you know people that are and you're interested in attending that session, please join us as well. You can check our social media or reach out to us, info@spondylitis.ca, for more information on that or any other questions that you might have. So again, thank you very much, Dr. Zumer. We really appreciate your time and expertise tonight.
Well, thank everybody for the questions. Really appreciate it.
Great, thank you. And we will hope to see everyone back again soon. Our next English webinars will be held in June, and we're going to be focusing on spondyloarthritis and disability. So again, a topic that is of interest to people I know in the community, and we'll be sending out more information on that soon. Please follow us on social media if you don't already. Sign up for our e-newsletters and information that we send out as well. And as always, if you have questions, don't hesitate to reach out to us. Thanks everyone, and have a great evening.